And for patients that have Peryonis, I mean, either after using Trimex or whatever the reason is, how do you prepare for those cases? Do you try to do a modeling? Do you know beforehand that you're already gonna do a graph?
I mean, for Peroni's, man, we can have a full
A full
2-hour
video? Yeah.
podcast about Peroni's disease. But yeah, when it comes to Peroni's, again, it's similar to priapism cases. I make sure to set proper expectations. I mean, you assess the severity of the curvature. Make sure that you have at least an idea of how bad that curvature is. I mean, don't tell them it's like, oh yeah, we're going to be able to do a modeling, procedure. This is going to be a straightforward case. And then all of a sudden you go in there and the guy has a, 120-degree curvature. You want to make sure that you know what you're getting yourself into. Make sure that both you and the patient are on the same page when it comes to what are the goals of the surgery. Is the goal to make the penis straight like an arrow, or is he okay to be what we call functionally straight, right? It's not the same thing for a guy to be a 20-degree curvature, which most of us have some degree of curvature. So again, you want to make sure that you set those, proper expectations. Is his goal to get back as much length as possible? You need to make sure he understands what are the risks involved and what are the expectations to set yourself up for success. So in a scenario, for example, like you mentioned, like if the patient has like a 90-degree curvature, like severe curvature, and he also has erectile dysfunction, I try to fix everything at the time of the implant surgery. There are different ways we can do this. Most of the time, again, with these severe curvatures, just placing the implant is not going to be enough. For example, a guy who has a mild curvature like those with a 45-degree, you can probably get away with just placing the implant and do, very mild manual modeling. Or probably do Paul Perito. He uses a scratch technique in which he, from inside the corpora, you can actually get a nasal speculum inside the corporotomy. And then he uses either a 12 blade that has like a little hook or the tip of medicine bound scissors. You can just scratch that plaque from the inside. And sometimes you're going to be able to model then later, and the penis will actually be kind of straight. I've used it before. You can actually bill for that. Just like
Really? Well,
you can bill for that just like if it was an incision of the Peryonis plaque. It's just doing it from the inside instead of
okay.
from the outside. So again, but however, if there is a patient who has severe curvature, if it's 60 degrees or more, I personally prefer to do a plaque incision with or without grafting. There's two approaches you can use to do this. Most people use a circumcision incision. They deglove the penis in order to access a tunica. If you need to elevate the neurovascular bundle for dorsal plaques, you can do so. If you need to, for ventral plaques and you need to, elevate the urethra, you can definitely do so. Me personally, I prefer to use a ventral incision. So instead of degloving the penis, I actually just, make an incision right along that ventral raphe,
Okay.
and I'm able to expose everything. There's also a video on YouTube about that.
Perfect.
And you can actually elevate both, the skin, dartos, and the neurovascular bundle all together. This way we can keep the skin attached to the glands at all times. And theoretically, we could avoid the risk of gland ischemia. I mean, there was a study back in 2017, for example, that looked at the risk factors for cases with gland ischemia. And they had 17 patients who had gland ischemia with penile prosthesis placement. And out of those 17 patients, 86% had a circumcision with degloving. So for
Wow.
this reason, when I was in my fellowship, Dr. Wang, who's my mentor, we published approaching these cases with the use of a ventral non-degloving incision. And then another thing that I personally do for these cases when it's severe curvatures and they do not have, the plaque is not calcified and there's no hourglass deformity, I would, instead of doing one incision at the point of maximal curvature, I do multiple incisions. And instead of going at the point of maximal curvature, I should go around it. And that way, with multiple incisions, those incisions are going to be smaller. And most of the time, I don't even have to place a graft. I actually plan to present my findings. I've done more than 35 cases, I believe now, using this approach, and I'm actually presenting it next month in this year's SMSNA meeting.
So you're not doing sutures, you're just doing the incisions.
So that is correct. So
Okay.
whenever we're placing a penile prosthesis, whenever we do Peryonie's cases and where you're doing a plaque incision with grafting, again, the biggest risk with that one is erectile dysfunction.
Yeah.
The good thing about these guys who also need a penile prosthesis, you don't have to worry about that.
Exactly.
Sometimes if the defect is less than 2 centimeters in size, you can get away without having to place a graft. So what I do is, because again, if you have a guy who has severe curvatures, again, 90 degrees, 100-degree curvatures, even 75-degree curvatures, and you make an incision at the point of maximal curvature, when you get that penis straight, you will have a very large defect that you're probably going to have to graft. And in order for me to avoid that, what I started doing was making multiple smaller incisions, and all those incisions are probably a centimeter and a half. Again, you have to close the neurovascular bundle, you have to close buccs, you have to close dartos, and all those will serve enough. They will serve as a scaffold to be able to cover those defects, and you don't have to worry about placing a graft. That being said, nowadays we have different types of graft. There are these hemostatic patches. For example, Tackle-Seal is one of them. That's the most common one that I use. And the good thing about it is you don't have to worry about sewing a graft, because we all know that whenever we do these Peryonie's cases and you have to sew a graft, that's 30 minutes that you have to add into your surgery in order for you to get that watertight, right? So I am one that what I use is a Tackle-Seal graft whenever I need to use it, specifically for these Peryonie's and erectile dysfunction cases that I'm using a penile implant.